Hi, I'm Dr. Jason Siegel, and this is Neuro Now. I'm really excited to be expanding our series of me sitting down and having interviews with some national and world experts in different fields of neurology. And today is no different. We have Dr. Philip Tipton, who is currently an assistant professor of neurology at the Mayo Clinic in Florida. He specializes in movement disorders and Parkinson's disease. And that's something that I get a lot of questions about. And so I'm really excited to sit down and pick his brain on the topic. Dr. Tipton graduated summa cum laude from the University of Tennessee with a Bachelor of Science in Biochemistry, Cellular and Molecular Biology, and a minor in music. He received his medical degree from Eastern Tennessee State University before completing a neurology resident at the Mayo Clinic in Jacksonville, Florida, followed by clinical fellowships in both behavioral neurology and movement disorders. Like I said, he is currently an assistant professor of neurology at Mayo Clinic in Jacksonville, Florida. He's also part of the Mayo Clinic Clinician Investigator Training Program. Dr. Tipton is engaged in numerous research activities focusing on neurodegenerative diseases like Parkinson's disease, with a particular emphasis on applications of deep brain stimulation and quantitative gait analysis. Dr. Tipton enjoys playing tennis, rooting for the Tennessee Volunteers, and spending time with his wife and two children. Like I said, I've known Dr. Tipton for several years. He's a fantastic doctor and an even better person. I hope you enjoy our conversation. Thanks. All right, I'm here with Dr. Philip Tipton. Dr. Tipton, I'm really glad you're here. I really appreciate your time. Thanks for being here.
Yeah, thanks for having me. It's good to see you, Jason.
Yeah, you too. You too. You're looking good. Let's dive right into it. You know that the topic for the week is Parkinson's disease and movement disorders. Um, I think a lot of celebrities have been diagnosed with Parkinson's. It's kind of something that we hear about. What is Parkinson's disease?
At its root, Parkinson's disease, it's a neurodegenerative disorder. And so what that means is that our brain cells, the neurons more specifically, are dying, they're degenerating. And in idiopathic Parkinson's disease, that's happening in a very specific area within the brain that produces a chemical called dopamine. And dopamine is a neurotransmitter. It's a chemical that is critical for us to be able to move. And so neurons begin to degenerate and then other neurons degenerate. And that's a process that spreads. And if we go back to that spot in the brain that produces the dopamine, those cells continue to die. And you have to have a certain percentage of those cells that die before you actually get these motor symptoms. When we get to this question of what causes Parkinson's disease, it's a really complex answer with no definitive answer. So we know that there are genetic contributions. There are even some genetic mutations that if you've got one, you're going to develop Parkinson's
Mm,
disease. But that's the minority of patients. There are also various toxins that we've been associated or have been termed to be risks for Parkinson's disease. But any one of those things doesn't usually seem to be enough to necessarily cause the disease. And so it's really this sort of mixture of all these potential hits, if you will, that lead to the disease. So if you picked off one of those things, you might help a subset of patients, but you wouldn't necessarily help what we refer to as Parkinson's disease as a whole.
What do people usually experience first? What are some of the first symptoms that might make somebody think, okay, there something's going on here?
We've all seen someone out in public where we see, their hand shaking. And so that's oftentimes something that patients will come to me about is a tremor. And but with Parkinson's disease, it's a specific type of tremor that occurs when the hand's at rest, when it's not really doing anything. And that's contra to the most common type of tremor disorder, which is called essential tremor, which is really more of an action tremor. So if you're going to write, sign a check or, shave your face, and I haven't done much shaving here, but shave your face, that's when those tremors come out. And that's very unlike Parkinson's disease, but oftentimes it can be difficult to make the judgment. You may see a particular type of muscle stiffness that we call rigidity, or a particular type of muscle slowness that we call bradykinesia. And so those three features together oftentimes make up the motor picture, if you will, of Parkinson's disease. But it really comes down to where the neurodegeneration is occurring in that particular dopamine producing area of the brain. Even though we tend to refer to Parkinson's disease as a movement disorder, historically it's a movement disorder, when it really gets down to it, when I'm seeing someone in my office and the concern is on Parkinson's disease, if we dig back further, and when I say further, I mean, 10 plus, even sometimes 20 years, we start to find that there are some non-motor features that really precede the onset of
Hmm.
motor features. Now, the caveat to that is that a lot of these things are kind of common in the general population. Constipation is one of them. Depression is also another one. But one thing that tends to be pretty unique to diseases like Parkinson's and a couple others in that family is this thing called REM sleep behavior disorder. And what that refers to is basically acting out of one's dreams. So there's a specific network within the brain that keeps us essentially paralyzed while we're in dream sleep. And it kind of makes sense from an evolutionary standpoint because, if you're running from a tiger in your dreams, you could really hurt yourself or hurt somebody else during sleep. So that's been reported in cohorts at Mayo Clinic, Florida, and other places as early as 20 plus years before the onset of those motor symptoms that I mentioned earlier. But usually, when someone's arriving at my office, they're starting to have some of the motor symptoms that I mentioned earlier. So they may be slowing down, their speech may get softer, slower, their face may become less expressioned. We call it mask like faces or reduced hypomimia. Um, Sometimes we'll hear about the shuffling gait, so the feet may kind of shuffle along rather than picking them up. Oftentimes, spouses will say, "Yeah, my husband's left arm isn't swinging as much as it used to," because Parkinson's disease is also a pretty asymmetric disease. So those are things that most people can kind of pick up on.
I
And
think you bring up some good points. As you said, there's a lot of overlap between some of those early symptoms. We don't want everybody who's having trouble going to the bathroom to freak out, or
right,
people who are having, yeah, as you're saying, tremors when they're shaving themselves to freak out. But it can be a scary thing because, again, a lot of I think the stigma we hear about Parkinson's disease and what we think we might know, again, from celebrities and things like that. So somebody is concerned they might have Parkinson's. They're concerned about a tremor. They're concerned about maybe they're falling, tripping, and things like that. They come see a neurologist. What happens then? What other testing is done? Is there any testing that needs to be done?
so whenever I hear that question, it always reminds me back to I think it was Bill Clinton that said he had the test for Parkinson's disease and he didn't have Parkinson's disease. And I always wondered, what exactly was that test he was talking about? Because there's actually not a specific test that tells you whether you do or don't have Parkinson's disease. So if you go to a neurologist or movement disorder specialist with some symptoms of Parkinsonism, and when I use the term Parkinsonism, I'm using that intentionally, and I'm specifically referring to those motor symptoms that I mentioned earlier. So if the neurologist is seeing those types of things, there are a few ways that you can go with that. Sometimes people will go straight to a particular type of imaging modality called a DAT scan. And by and large, that's usually what people are referring to when they say they have the Parkinson's disease test. But it's really a misnomer because that test can be abnormal in diseases other than Parkinson's disease. It can also be normal in early stages of Parkinson's disease. So it's really not a Parkinson's disease test so much. But what I do and what a lot of neurologists will do is actually trial patients on a specific medication. And there's two reasons for that. One is we know that patients with Parkinson's disease respond exquisitely well to this medication. And the one I'm referring to is a medication called Levodopa. Brand name is Cinemet, but it's generic now. So Levodopa. And so patients with Parkinson's disease will respond exquisitely well. And so if someone comes back and says, "Gosh, I'm significantly better," then you've got a pretty good footing that you're dealing with Parkinson's disease. Plus, it's the most effective treatment for Parkinson's disease as well. And so you've already got someone started on the treatment of choice. So it's really you can't really go wrong with a levodopa trial. And then once you know where you're at with that medication, then you kind of know what trajectory you're dealing with. So those are the first things that I would do.
Yeah, and I'm glad you brought that up. Where Dr. Tipton and I trained, there's a neurologist who is, shall we say, advanced in his career. I don't think we can call him old. You know who I'm talking about because he's very young at heart. We had asked him one time, in your career, what has been the biggest advancement in neurology? And we're thinking something about strokes or something. He said, the development of levodopa has been for him the most important, biggest advancement in neurological care in his career. And then that was, I think, really meaningful because he would say, just as you said, people would be frozen. They couldn't move, they couldn't walk, they couldn't feed themselves, and all of a sudden they could get up and have almost a normal functioning life.
I would dovetail on what you said a minute ago, Jason. That movie Awakenings, Oliver Sacks. I mean, that's if no one's ever seen it, I mean, that's a good example of what happens when you give patients with Parkinsonism. Those patients didn't necessarily have Parkinson's disease, but same kind of scenario, where they were going from just kind of a, hate to use the phrase, locked in um, state to being animated. So with levodopa, the field has kind of swung in a couple different directions over the past few decades, and levodopa has been around since I believe the 50s or 60s. So it's a very old drug. It's a good drug. It works. We know a lot about it, but levodopa is not a drug or a disease modifying therapy, as we call it. It doesn't really do anything to the disease process. It's really kind of a supplement. In fact, I'll sometimes liken it to insulin for a type 1
Mm,
diabetic.
mm,
Pancreatic cells are no longer producing insulin.
mm.
And so what do? You give insulin. Levodopa is one biochemical step away from pure dopamine. But we don't give you dopamine because you'd be sick as a dog and weird things would happen to your blood pressure. So we give you levodopa. And so the what's happening though is that the disease is progressing, and so you may have to change how you're dosing the medication forward. What happens though as the disease progresses is that the drug begins to wear off more quickly. So early on in the disease, you could be taking 1.5, 2 tablets 3 times a day. You might miss a dose and you don't even know it. You might miss 2 doses and you don't even know it. You're kind of in this honeymoon period, and that can last several years early on in the disease. But then the life of the drug, or how quickly it's cleared in the body, begins to trail off. And so the challenge for the patient and the practitioner is to try to lengthen out those doses. And so sometimes you have to add more doses. So I tell my patients that as the disease progresses, we're usually not talking about more tablets per dose, it's more doses per day.
Hmm.
And then that becomes, the challenge, the chess match of the disease
Hmm.
moving forward.
You had mentioned a lot of the motor side effects, low facial expression, not lack of movement. Now. One of the reasons that we're doing this video this week is because maybe the most famous person in this country nowadays with Parkinson's is Michael J. Fox. And not to make this about him, but he made a public appearance. And to me, he looked anything but lacking movement. And his face was very expressive. And he was kind of almost looked very restless. And uh, for somebody who's out there who sees Michael J. Fox moving around almost too much, how does that how would you reconcile that with the diagnosis of Parkinson's disease?
So, just as I mentioned that when we have low dopamine, we'll have those symptoms like decreased movement. You can go too high and have increased movement. So, um, as the disease progresses, we're trying to get into what we call the therapeutic window. So in Parkinson's disease, we'll oftentimes use terminology like the on state and the off state. So off state is when you've got all your symptoms of Parkinson's disease. Maybe you wake up in the morning, you're stiff, you're rigid, you've got the resting tremor, all of your symptoms are there. You take levodopa, and the goal is to get you in the on state, meaning reduction or maybe complete elimination of all those symptoms. But what can happen though is we can push beyond just the on state into an on state with what we call dyskinesias or excessive movements. And I always preface this with, I don't mean to pick on him, but everyone knows who I'm talking about when I refer to Michael J. Fox. And so when I talk to my patients about dyskinesias, I usually use him as an example because he's in the public eye all the time. And so, you'll have these sort of non-purposeful movements that almost appear like someone's kind of restless. And so those are what we refer to as the dyskinesias. Whereas levodopa is converted into pure dopamine, that dopamine has to act on a dopamine receptor. Dopamine itself doesn't do squat in the body until it's acted upon until it activates a dopamine receptor. We've got synthetic ways of activating those receptors, and these are called the dopamine agonists. And so there's a whole class of medications, these dopamine agonists, that came out a few decades ago. And people thought, oh, this is a way to mitigate that risk of dyskinesias. We can save levodopa till the bitter end, and use these medications because they won't cause the dyskinesias. But what we know from several studies that have been done and done well is that the risk of dyskinesias is about the same in both of those. And so when we have surveyed our patients, if we ask them about dyskinesias, that's only half the story. So oftentimes the dyskinesias are not nearly as bothersome as the off symptoms. And so given the choice between the two, patients say, I would rather have some dyskinesias than have off symptoms.
So we talked about levodopa, we talked about the dopamine agonists. You touched a little bit on deep brain stimulation. Can you talk a little bit more about that and maybe what's on the horizon, or what are people trying to do to help these patients, coming down the road?
Yeah, deep brain stimulation is something that I get really excited about talking about because it's incredibly fun for the practitioners to see how much of a difference it can make in patients' lives. And levodopa is the same way too, but there's something extra special, at least to me, about deep brain stimulation. And so what that involves is insertion of a lead. So it's an electrode, a surgical procedure, insertion of a lead. And I shaved my head just for this so that I can demonstrate. So insertion of a lead towards kind of the front portion of the head. And as the name suggests, it's deep brain stimulation. So using a very precise technique, the lead is inserted into the brain to a pre-specified target. And when we get to the right target, without going into the details of how we do that, because that's probably another talk for another day, when we get to the right target, we can have improvements in bradykinesia. We can have improvements in rigidity. We can have improvements in tremor. We can actually even have an anti-dyskinetic effect, so we can get rid of those dyskinesias. So there are really a lot of things that deep brain stimulation can do. So I always say, if you've met one patient with Parkinson's disease, you've met one patient with Parkinson's disease. Everybody is completely different. And the same thing goes with deep brain stimulation and how we treat patients with Parkinson's disease, because just getting it into the right spot, if you will, is really only part of the story. It's providing the right stimulation or electrical prescription, if you will, to meet someone's symptomatic needs.
How about real disease modifying agents? Are there any? I mean, that has to be an area of focus for some big pharma company somewhere. Is there anything that could be a potential that could actually just halt this disease?
Yeah, so short answer is there's not anything right now. It is definitely an area of interest. I think probably the closest thing to a disease modifying therapy that, I guess I should say, the most promising, is with some patients that have specific genetic mutations. And there are some clinical trials right now of medications that would target a pathway that has to do with the gene that's abnormal. So without going into the nitty gritty details, it would be a disease modifying therapy. However, as I mentioned earlier, a lot of these genetic mutations are really only the minority of patients.
So somebody gets diagnosed with Parkinson's disease. They're on Cinemet. They're feeling good. What can they expect long term? Again, I think there's a very scary stigma about it, that a lot of people I've talked to feel very worried about the diagnosis. But realistically, what can somebody expect after they're diagnosed?
Yeah, the I think you used the word earlier, stigma, or if you didn't, I was thinking it. But when Parkinson's disease was first described in 1917, I think when it was first published, um, the picture of Parkinson's disease was very different than it is today. In fact, there's a classic image of an elderly gentleman that's hunched, and you can kind of tell from the illustration that he's not moving very well, looks pretty miserable for all intents and purposes. And there was a paper that came out just a couple of years ago about how our image of Parkinson's disease really should change. And so this paper showed lots of different images of people, jogging and doing different things, and they all had Parkinson's disease. And I think that that's really true. However, I think that the general public is kind of lagged behind in terms of their public perception, because the things that you're seeing in the public eye, i.e., Michael J. Fox, still look kind of rough. But patients with Parkinson's disease can live very full, very fulfilling lives for a very long time. And whenever I'm diagnosing a patient with Parkinson's disease, I always stress that we're talking about a slowly progressive disease. There are other neurodegenerative diseases that are not slowly progressive, but Parkinson's disease, Alzheimer's disease, both of those are really slowly progressive. So I tell people this: we all have good days and bad days. So yeah, Monday may look a little different than Tuesday, but this is not a disease where next week you're significantly worse than you were last week, or next month you're significantly worse than last week, or even next year you're significantly worse than last year. This is something that's slowly progressive over decades. And so when it comes to overall life expectancy, there's not a major difference either. So I think those are some important points to take home. Now, life expectancy is different than quality of life, and I already mentioned some of the aspects that relate to quality of life. We have kind of fallen into the trap that a lot of folks fall into and become hyper focused on the motor symptoms, but the non-motor symptoms can also be. I oftentimes refer to the motor symptoms as the tip of the iceberg, because sometimes the non-motor symptoms can be as much of an issue, if not more. And so those could include things we've already talked about: constipation, depression, sleep disorders, but also issues with blood pressure regulation, bladder and bowel function, and several other things as well. The good news is, though, we have symptomatic treatments for almost all of these things. And so, as long as you've got a practitioner that's looking at the whole piece and not, just focusing on getting rid of your tremor, I think that you've got a good chance of having a solid quality of life for a very long time.
To some of the questions I got through social media, particularly about other drugs, other medications maybe used for other purposes that could cause, induce Parkinsonism or other similar motor disorders. Can you touch a little bit about Parkinsonism as a consequence of medications or other drugs?
Yeah, this largely goes back to dopamine. So any medication that can have a dopamine blocking effect is fair game for causing Parkinsonian symptoms, the ones that you just mentioned, Dr. Siegel. So some of the more common ones used, the most common ones are going to be some of the anti-nausea medications like
Mm.
Reglan. In fact, I remember one of my mentors, even before I was in medical school, had a patient who came in Parkinsonian, pretty newly Parkinsonian, and he saw the medication list, and this Reglan was on there, and I don't remember why, but he said, "I'm going to cure that patient's Parkinsonism," and and so he was able to take them off of the Reglan, get them on something else, and then the next time they came, oh, I'm sorry, they arrived in a wheelchair. The next time they came in, they were walking, and then the
Wow.
next time they came in, they were walking briskly. I mean, it was just remarkable. So medications, even though they all have their purposes. They can always have side effects too. And that goes for over the counter stuff as well.
Hmm.
The other class of medications besides anti-nausea medications are the antipsychotics. There's a laundry list of antipsychotics. Probably the biggest culprit, doesn't get used as much nowadays, but we still see it, is one called Haldol. It's one of the older antipsychotics, and so a lot of people will say, well, the newer ones don't cause Parkinsonism, and so sometimes they're referred to as first generation and second generation antipsychotics. But truth be known, they can all do it. It's just usually an issue of dosing. So if there's ever concern about drug-induced Parkinsonism, the answer is try to stop the drug with the guidance of your physician, of course. Try to stop the drug and see if it goes away. Oftentimes it will, sometimes it won't, but that's the first step in trying to get to the bottom of that problem.
Can these drugs, say the antipsychotics, for example, cause other motor disorders other than Parkinsonism?
hmm Yes, they can. So sometimes you can get something called, particularly with the antipsychotics, something called tardive dyskinesias. So we already talked about the term dyskinesias. It's kind of that excessive movement. We used Michael J. Fox as the example for that. But sometimes patients will get on an antipsychotic, and the most common kind of presentation is that they'll get these kind of mouth movements and smacking movements, and just it's dyskinesias, but it's primarily around the mouth, and they can be very bothersome. Even if it's just a social nuisance, that can be an incredible social nuisance.
Hmm.
But sometimes they can even be painful too. That's not uncommon with the antipsychotics. Again, the first answer is to try to remove the what we call the offending agent, the medication, if able. But sometimes that's not possible, and other medications are needed to help control those symptoms.
You had mentioned antipsychotics that brings to mind to me other mood stabilizers, other maybe psychiatric drugs. How about things like SSRIs, antidepressants? Are they known to cause Parkinsonism or other kind of movement disorders?
That's a great question because I already mentioned that depression is common in Parkinson's disease. And so oftentimes we're talking about prescribing an SSRI or an SNRI. Those are the common medications for depression. Sometimes they can be used for anxiety. Um, while there are case reports of Parkinsonism being caused by these medications, by and large, it's not something that I would usually blame Parkinsonism on.
Hmm.
Um, Really, when it comes to a movement disorder related to those medications, the most common one that I see is a tremor, not a Parkinsonian tremor,
Hmm.
but as a tremor.
Hmm.
And so, again, if that's what we're thinking is the cause of the tremor, we try to lower the dose or discontinue the medication to prove the point. And if that is the causative agent, fortunately, there's a laundry list of those medications, and we can
Yeah.
usually try another one.
Where can people go to learn more about Parkinson's and other kind of neurodegenerative disorders?
For Parkinson's disease, I think we've said Michael J. Fox about 1,400 times on this episode, but Michael J. Fox Foundation is a good resource. The Parkinson's Foundation is also a very good resource, as well as the APDA, the American Parkinson's Disease Association. They've all got different resources that can be really helpful. Um, as far as other neurodegenerative diseases go, the Alzheimer's Association has a website that not only focuses on Alzheimer's disease, but they have information about other neurodegenerative diseases too. So I would go there as well.
Good, and we'll have links to all those websites in our YouTube description. Where can people learn more about you if they want to see more of your face, hear more about what you have to say? Do you have any outlets?
So I have a an old podcast. We're no longer running the podcast, but we've got a lot of good episodes. And it's if you search Google "Long Live the Brains," you'll find the podcast, and you'll find some old YouTube videos as well that kind of dive into some of the things we've talked about today, as well as other neurodegenerative diseases too. They're complex diseases, and sometimes we as practitioners can kind of get buried in the jargon because we're seeing it day in and day out. But the podcast really tries to give a 360-degree look at what the disease looks like from all angles. So patients, caregivers, practitioners, social workers, you name it. So I think it's a pretty good resource too, and fun too.
Yeah, I agree, and I'm glad you brought that up because I've watched many of those videos, and I think that's a really good way of describing it. You really see the disease from various different angles through a lot of different lenses, and I think that's a very cool way. As as a doctor, I think it's cool to switch perspective, and of course, if you're somebody from that perspective, it's good to know that you and other physicians are trying to understand their viewpoint. So yeah, I really recommend Long Live the Brains, YouTube, and the podcast. Before I let you go, maybe the most important question I ask you all night. The Tennessee Volunteers are currently ranked number 3 in the
Yes.
AP poll and 4 in the coaches poll. So I got a two-part question. One, how far are the Volunteers going to go this year? And is the second part, the foundation, the culture built for longevity and success?
Oh my gosh. Oh man. Um, so my heart says it's a national my heart says it's a national championship this year. My head says we're gonna have a hard time getting past Georgia.
Hmm.
But I've there's a couple decades of history going into what I'm about to say next. I actually do think that the culture is changing there for the better. So I'm excited, and I haven't been super excited in a while. So that's good. Yeah.
Very good. Well, thanks so much, Phil, for joining me. This has been great. I hope our viewers learn a lot. To the viewers, please, write your comments, questions in the description. If you have comments for Dr. Tipton, I'll read them. I'll share them with him if they're appropriate questions. And be sure to like, subscribe, share this video if you found it interesting. Thanks a lot, Dr. Tipton, and I'll see everybody next time.
Thank you.